Hello, everyone. Welcome and thank you for attending this webinar on advancing blood culture practices. We've got some really great speakers. My name is Ian Fraser. I'm a field application specialist and the blood culture best practice ambassador at bioMérieux. And I'm going to be your chair for today. Due to some technical difficulties, Pete and Adele are unable to speak from University Hospitals of Morecambe Bay, where they're discussing improvements they've made to their blood culture pathway using a multidisciplinary approach and also introducing things like new blood culture packs in order for people on the wards in departments to take blood cultures to aid staff in the collection of the bottles. Although pre-recorded videos will be taken and shared with everybody after this webinar. Questions will also be welcomed towards the end of the session. And I would just like to introduce our first speaker, which is Mark Prescott, Senior Assessment Manager from UCAST, who will be discussing a risk-based approach to the assessment of the blood culture pathway. Take it away, Mark. Thank you.
So, yeah, as Ian mentioned, my name is Mark Prescott. I'm the technical focus lead for microbiology within the MedLab section at UCAS. So I've been asked just to give a presentation today around the risk-based approach to the blood culture pathway. I've done a similar presentation in other sort of organisations and got a sort of a variety of audiences. So this has sort of gone beyond laboratory staff at different times, which has been really quite useful. I'm just going to have a quick look at the guidance that's out there around management of blood cultures. So we're going to be looking at the SMI that I'm sure most people will be familiar with, also the GIRF report, and then the most recent publication, which was this NHS England review from last year. These all tie in quite nicely with ISO 15189/2022, and especially the transition that we're going through at this moment. So I'll tie those in together and just give a little bit of detail as to how we're going to be assessing this going forward. So just touching on the SMI, which I think everyone will be familiar with who's worked in the microbiology lab. This is B37, which is for investigation of blood cultures. This has been around for some time, so the current version I think is from 2019. These are all sort of being updated at the moment. This goes through some timeline critical points around the management of blood cultures. And the first one it sort of goes into is this time from collection of the blood culture to its incubation on an analyzer, and talking about that as being ideally within 4 hours. This is the one that seems to get more attention than any of the others, which I'll come to a little bit more detail shortly. There are a few others in there as well. So it talks about ideally getting a gram stain within 4 hours of flagging positive, getting ID and sensitivities within 24 to 48 hours. And there's also some guidance on when to issue reports, so that getting preliminary negatives out at 48 hours wherever possible, and final reports at 5 days. There's other examples of good practice in there as well. So it talks about an optimal procedure for collection of blood cultures, noting that there's no particular difference between arterial blood and venous blood. It talks about the number of blood cultures, so going into 2 sets and even 3 sets. And also the timing of samples, whether you take these samples at different times of the day, different sites of the body, and even bearing in mind any sort of antimicrobial therapy that patients might be on. And specific reference as well about the volume of blood, and stating that there is a direct link between your chance of getting a positive blood culture. There is a link with yield here as well, and important to follow the manufacturer's guidance as regards the fill volume of blood culture bottles. But the SMI does recognise that these factors are affected by various internal and external issues, and that these do vary very much by laboratory. So I will be focusing on those a little bit in the next sort of few minutes. But the SMI does also recognise that there is a lack of robust evidence to support these recommendations, especially that 4 hours. It is considered a bit contentious at times. There are some people who don't completely agree necessarily with that 4 hours. It's difficult to pin down where that specific time came from. But it's really, a lot of it is just following common logic, that it's, as with any sample, it's ideal to process them as quickly as possible. Now, following on from the SMI, which we've obviously been familiar with for some time, we've got the GIRF report. there's little about blood cultures in here, but there is recommendation number 11, which states that laboratories should ensure blood cultures are loaded onto their analyzers within 4 hours of collection. Now, the wording of this is slightly different because it is saying ensure blood cultures are loaded, which is a little bit further than saying the SMI, which is saying that ideally they should be loaded within 4 hours. So the wording is a little bit stronger there. The only other mention around blood cultures in there is to get the neonatal blood cultures reported within 36 hours. I think I might have slipped a slide there. So the next one was the blood culture pathway. This is PAR 686. This is version 1.1 from March of last year. Now this uses outputs from various work streams, so particularly the MR Diagnostics Improvement work stream at NHS England. Their purpose was just to improve processes regarding sepsis management and blood cultures. Now, this document makes direct reference to the SMI B37, which we've just been through. It also makes reference to S12, which is going to be the sort of the new SMI related to management of blood cultures and sepsis. So this is the syndromic algorithms that we're now moving towards. And it does note that by following the guidance in these documents, we can improve the detection of bloodstream infections. And there is a feeling that there is opportunity for improvement here. We can improve the speed of detection of positive blood cultures, which itself leads to better outcomes in patients with sepsis. Now, the way I look at this, there are 3 key points within this that are worth looking at. One of them, or 2 of them, are related to volume. One of them is that it does recommend 2 sets of blood cultures, and noting that ideally there should be 8 to 10 mils of blood within each bottle. There's a slight quirk in the document that it later refers to having 40 mils of blood total, which means 10 mils per bottle with the 2 sets. So there's a little oddity there that I don't think has ever been corrected, but it does sort of say to follow the manufacturer's guidance as well as regards the fill volume. So 2 things to consider there. And then the third one, back to this 4 hours. So this is the time from collection to the analyzer. And it uses the wording to recommend that sample bottles are incubated on the analyzer as soon as possible, and ideally within a maximum of 4 hours. So it's more following the wording of the SMI to say ideally within 4 hours, as opposed to the GIRF report, which is saying they should be on in 4 hours. And then there are just 4 recommendations that come out of this blood culture pathway document to the end. The fourth one there is the key one, as will be regarding us at UCAS here. So this is about using this guidance to improve regulation and accreditation. Now, as many of you will know, of course, we are going through the transition to ISO 15109 2022 now. And this guidance fits in really well with this, because this is all about patient-focused approach. It's all about the management of risks and improving patient care, which is the key difference with the 2012 version of the standard. And that fits in very timely, as we would think, with the issue of this blood culture documentation. Now, in terms of how we're going to assess this, I think this is the area that some people are most interested in. We at UCAS have been working quite closely with NHS England on this, and they're also aware that the principles in this guidance and this pathway document is not new. It's been around for some time, as I mentioned, in the SMI, and recognising this risk-based approach with ISO 15109. So we have been working with NHS England on this because they are keen for us to implement the sort of recommendations from this pathway document, and we'll be working with our assessors on this in terms of the best way to assess it. What we need to be careful with is that this is guidance, and with guidance, we're not assessing guidance specifically, we're assessing against ISO 15189, but we do need to consider the guidance within that. So I think that the first thing really to point out is that there is not going to be any mandatory enforcement of this guidance. Those key points there about the volume and the collection of blood cultures, we're not going to be sort of coming out hard on people who are not following this immediately. It's what we want to see is that laboratories are aware of this guidance and that they're taking it forward. They're going to work on it and try and identify improvements, because there are outside influences that affect this, and we hear this very often when we talk about blood cultures and other things as well. So things, we've got no control over these external influences, and transport is one that comes up very often. All the trust transport team have sorted all that out. Sometimes labs get a little bit of input into delivery time. Sometimes they get almost none. because that just doesn't fit with the standard at all. Laboratories have a sort of requirement to get involved with transport of blood cultures. And there's also cost and resource pressures as well. We fully understand that, and this especially relates to the collection of the 2 sets, which I'll touch on in a moment a little bit more. In terms of laboratories now, we are seeing far more multi-site networks coming into place now. They're becoming much more common, and there's lots of different ways to manage these. They've all got their own little functions and ways to do things, and it's especially how to manage blood cultures at different sites. So some organisations have taken the route of having blood culture analyzers on these different sites. So they may then just send the blood cultures from each hospital, put them on the analyzer, and then transport the positive bottles to one central laboratory where all the blood cultures are processed there. I've seen that working in different situations. It works quite well. Obviously, we have plastic bottles now rather than glass, so it's a lot safer to do that. Good IT links as well, so everyone knows what's happening to them. But that's not the only way to do it. There are other organisations that don't have analysers at multiple sites, and they're really going more down the route of just having very good transport networks and just transporting all the bottles to one site or maybe 2 sites. Again, that can work. It's just having that good transport in place with regular collections. And resource for loading and removing bottles. Microbiology labs don't always have sort of full 24/7 services, so that removes this option of putting blood cultures on the analyzers out of hours. Many can take the steps of moving the blood culture analyzer into another department, so putting it into specimen reception or blood sciences and getting their staff to load the blood culture bottles overnight, even if they're not taking the positives off. That requires their buy-in as well, of course, and they may need resource to help out with that. And the other one is the resource for multiple sets. This is the one that does get the most attention, really. Laboratories will say that we don't have the resource for this. It requires additional staff. It requires additional funding for bottles. It requires additional blood culture analyzers. So lots of little issues around that one. But as I mentioned, the key consideration from the perspective of UCAS is really that laboratories are aware of this guidance and maybe setting baseline data, doing initial audits and working out what your transport times are, what kind of fill volumes are you getting, and really monitoring this via performance indicators. And what we want to see is that labs are doing this and have done it, and then just really building on it from year to year as we go from assessment to assessment. And it just requires ongoing monitoring, really. We are aware that there's going to be difficulties with resource and things like that, and getting other clinical teams involved. We would expect to see some wider discussions around the implementation of 2 sets. And we know that we're not going to see changes overnight. There's just this expectation that laboratories are seen to be doing everything they possibly can, even if it's slow at first. So, if you do your initial monitoring and you can see that, the fill volume is low, and I've seen this in a number of sites, even 3-4 mils of blood in these bottles, and particular locations have been identified as being the key culprits here. So it's really having a look at your user information. Do the clinical teams collecting the blood, do they really understand the importance of getting that 8 to 10 mils of blood? Appreciating completely that some patients are difficult to bleed and there can be difficulties with that, but really making people aware. And if you can see certain sites that are not doing this, going back to those sites and having more conversations with them about collecting the correct volume of blood. And similarly with resource, if it does come down to the 2 sets, using your lab directors and using your clinical leads and taking it further up into the management team at the hospital, even to the far of the chief executive, and explaining, we may need the resource for this. And you may get to the point where you just hit a brick wall and you can't improve things anymore. And that is something we will look at down the line as assessments move on. But really, for now, it is just about laboratories being aware of the guidance. So just in summary, this guidance and recommendations, they're not new. They've been around for some time now. There is a lack of data to support this 4 hours. We do understand that. It's more seen as good practice, really. We have assessed these guidance before on assessments, but it is taking more of a focus now because of the discussions with NHS England and also because of the ISO 15189 update. But yeah, just in final conclusion, we really just want to see that you're aware of this, you're monitoring these figures, and that you're acting on it as you would with many other things. And we'll just hope to see improvements from subsequent assessments. That's everything. Thank you very much.
Thank you very much, Mark. That was brilliant. Definitely can echo what you've said. Being on site myself, where there is struggles to implement these changes, but I guess ensuring that everybody really knows what the guidance is definitely the best first step. So thank you very much.
Okay.
I would like to now introduce our next speaker, who is Frank Brimsey-Jones. He is a managing consultant from Aquarius Population Health, and he will be talking about the economic evaluations in the blood culture pathway and talking around those pre-analytical steps. Thank you very much for joining us, Frank.
Thank you. Hello everyone, it's great to be able to talk to you all today about economic evaluation within the blood culture pathway. I'll give some background to the topic, talk through the evidence, particularly the economic evidence, and then open up for questions at the end. I'm Frank Brimsey-Jones. I'm a managing consultant at Aquarius Population Health. I'm a health economist, though these days I do a range of quantitative and qualitative research, and I've led a number of Aquarius projects conducting economic evaluations within the blood culture pathway. Aquarius Population Health is an independent healthcare consultancy. We work with public, private, and non-governmental clients around the world. We work across a range of disease areas, but diagnostics is one of our specialist areas, including blood testing. The Improving the Blood Culture Pathway report was published in 2022 by NHS England. It includes 2 best practice guidelines for the pre-analytical stage, although really there are 3. Collection of 2 sets of blood cultures, ensuring the bottles are adequately filled, and getting them to the analyzer within 4 hours. The report also refers to the National Blood Culture Audit, which was conducted in 2018-19. And the report says that the audit showed there's substantial scope for improvement in terms of adoption of the UK SMI standards and then these best practice guidelines. Levels of compliance with the guidelines vary across the country, as do the pathways in terms of the technology used, the people, the kind of workforce, and also the care pathway. And they vary not just among sort of underperforming or non-compliant areas, but also in terms of optimized areas as well, and the way that they've achieved optimization. This also varies. One of the key themes that we've come across is journey times, where labs are centralized. That can affect compliance, as can limited opening times as well, and trying to ensure that the timelines are compliant 24/7. More generally, studies have shown that around 1/5 to 1/3 of patients with bloodstream infections are not on an effective antibiotic, and it's really important to try and address that because it has important implications for patient health and healthcare resource use. So looking at the evidence then, and looking at the evidence divided up according to these different guidelines. So first, the number of sets of bottles. A study in the US found that when 1 set of bottles was used, the sensitivity was 73%, compared to when 2 sets of bottles were used, the sensitivity was around 90%. So a really substantial improvement in the performance of the test when compliance is achieved. And then moving on to how full the bottles are. So a French study found that when bottles were inadequately filled, the positivity rate was 3.8%, versus when the bottles were adequately filled, the positivity rate was 11%. Similarly, there was a US study that found that when the bottles were inadequately filled, there was a positivity rate of 8.2%, compared to when they were adequately filled, there was a positivity rate of 12.2%. So again, substantial improvements in performance when the best practice guidelines are complied with. Now moving on to looking at the timeliness of the pathway. So an Italian study found that when the pre-analytical times were reduced from 13 hours to 1 hour, the positivity rate increased from 11% to 13%. So again, the test performance was dependent on compliance with the best practice guidelines. Then there was a Swedish study. This study is looking at the time until patients receive appropriate antimicrobial therapy. So that's going to be impacted by the pre-analytical time, but it's also impacted by the rest of the pathway, because this is dependent on the full length of the pathway. as a reference, they used a time of 0 to 12 hours, and they then compared the mortality rate using a waiting time of 12 to 24 hours, 24 to 48 hours, 48 to 72 hours, and 72 hours plus. And the odds ratios are reported on the slide, and you can see that there's around a sort of 50% increase in the mortality risk for those longer waits of 2 to 3 days. So a real substantial impact there on patient health as a result of speeding up the pathway. And then one of the consequences of the compliance with the guidelines is the impact on patient length of stay. And so we've got a number of studies here. So the first is a UK study that compared false positive patients with true negative patients. So this is patients who their underlying pathology is the same. It's just that some have been effectively misdiagnosed. And the study showed that there was an additional 5.4 days of stay in hospital for the false positive patients compared to the true negative patients. Then there is a US study which found that patients receiving appropriate empirical antimicrobial therapy had an average stay of 7 days compared to 10 days for patients who had inappropriate antimicrobial therapy. So if patients receive appropriate treatment, then they are discharged from hospital quicker. If patients receive inappropriate treatment, then they have an increased hospital stay, which is sort of avoidable. And then the final point on this slide is around the fact that if patients have inappropriate treatment, then they're at greater risk of experiencing complications like sepsis or C. diff as well. And again, these adverse events can also lead to increased length of stay. And so thinking about this holistically then, we've got a sort of economic framework on the slide here. So you've got the direct impacts of guideline compliance, which is in terms of better test performance and reduced testing time. Better test performance means that you increase the use of appropriate narrow spectrum antimicrobial therapy. Reduced testing time means that you get patients onto the appropriate narrow spectrum targeted antimicrobial therapy quicker as well. And then the overall impact of that is patient outcomes in terms of lower mortality, lower morbidity, but also reduced healthcare costs in relation to the reduced length of stay. And finally, improved antimicrobial therapy stewardship as well, because you're reducing inappropriate use of antimicrobial therapy, and you're reducing the use of the broad spectrum antimicrobial therapy as well, reducing the contribution to antimicrobial resistance. There are a number of existing economic evaluations of the impact of compliance with these guidelines. The first we've got on this slide is a US study. The study looked at the impact of using 3 sets of blood cultures compared to 2 sets of blood cultures, and it found a saving of around $500 per patient as a result of an improved detection rate, so improved test performance. Second, we've got a study in China looking at optimizing the blood culture pathway in terms of reducing the pre-analytical time from 10 hours to 4.5 hours, but also increasing blood volume education for healthcare professionals to help ensure that they are compliant with the guidelines around adequately filling bottles as well. This study found a saving of around $1,700 per patient in relation to reducing antimicrobial drug use, and also a saving of $9,500 per patient as a result of reducing hospital stays. Now, when conducting economic evaluations in this area, there are a number of challenges, sort of methodological challenges, that need to be overcome. The first challenge is that much of the clinical studies that are published are looking at compliance with each individual guideline in isolation, but there's not really many published studies that look at the impacts of complying or not complying with all 3 best practice guidelines combined. And so assumptions need to be made about the relationship between the different guidelines. We've tended to assume so far that they're independent, which means that sort of A and B and C is the same as A plus B plus C. But we've also conducted scenario analysis to test our results to see how sensitive they are to this assumption. there's substantial heterogeneity between different trusts, both in terms of their sort of starting point and their current level of compliance, but also the way in which their pathways are designed, the workforces that they have in place, the technologies that they're using. Economic modelling always requires a degree of sort of simplification and generalisation. So you have to focus on what's happening in a typical trust and what happens to a typical patient. But you can use some uncertainty analysis to run scenarios that looks at, well, what if the pathway was like this? What if the pathway was like that? So that's helpful as well. And then one other option is to potentially use real-world evidence to try and get an even closer approximation of the variation between different areas. But that leads on to another challenge, which is that in the UK currently, real-world evidence in this area is quite limited. And so we've generally had to combine evidence from different countries and territories and then validate that with expert opinion by sort of interviewing people currently working in the NHS. But as more real-world data becomes available, particularly from the UK context, we'll be able to use that to refine the economic modelling and create more valid and more accurate results. And finally, two more challenges. So one is that most of the models that have been developed so far are looking at individual patients and individual hospital episodes, so maybe around sort of a 30-day time horizon. That works for most of the sort of economic considerations in this area, but when it comes to antimicrobial resistance, that's a challenge that is happening at a global scale and over many years. And so it's not really possible to formally include the economic the economic impact of antimicrobial resistance within these models directly. The way that we've addressed that so far has been reporting reduction in days of inappropriate antimicrobial therapy, and then allowing the reader to infer what the relevance of that is to antimicrobial resistance. But hopefully in the future, maybe more sophisticated models might be able to directly incorporate the economic value of reducing inappropriate antimicrobial therapy use. And then finally, optimization of the pathways and compliance with these best practice guidelines is not one intervention, it's lots of interventions combined, as well as changes to the pathway, changes to workforce, etc. And so you have a choice of do you evaluate sort of the whole pathway and the whole thing, or do you evaluate specific technologies in isolation? And we've tended to do a bit of both, but attempts to model the pathway as a whole generally haven't included the technologies. It's been sort of technology agnostic, but I think in the future that will be the focus will be creating models for the whole pathway that include all of the different technologies together to really understand the way in which the different technologies and interventions complement each other. This slide is giving a list of some of the examples of different technologies that are becoming available. So you've got some technologies that are focused on the blood collection and then transportation. You've got some technologies that are sort of rapid tests, point of care tests for diagnosing the pathogen. You've got rapid technologies for testing for antimicrobial susceptibility to ensure that patients get the right treatment and that they're not sort of resistant to the treatment. And then finally, you've got use of AI as part of the lab process to aid in diagnosis. So now we've got a few case studies. So the first case study is a piece of research we conducted for a point of care test for patients with suspected bloodstream infection in Ireland. And this was looking at what group of pathogens was responsible. And the results were that the test is not only sort of life-saving and leads to better health outcomes, but it's also cost-saving because the reduction in length of stay offset the cost of the technology. This study is published in Informatics in Medicine Unlocked, and the reference is at the bottom in case you're interested in following it up. And then another case study here of a rapid diagnostic test for neonates with suspected sepsis in England. And again, not only did this lead to improvements in patient outcomes, but it also led to reduced costs via reduced length of stay. This study was published as a supplement in the Independent newspaper, and it's still available online if you use the reference at the bottom. And so in summary then, current practice is really varied, but there's not consistent compliance across the country with the best practice guidelines. Adhering to the guidelines is really important because it improves patient outcomes, and it can also reduce healthcare resource use via reducing length of stay, reducing adverse events as well. Comprehensively evaluating the economic impact of optimizing the blood culture pathway has a number of methodological challenges. These challenges can be overcome to an extent, but they're just sort of limitations of research in this area. Some aspects of value are easier to demonstrate than others. So demonstrating the economic impact of improvements in test performance in the pathway is very straightforward. Demonstrating the economic impact of faster results, that's sort of moderate difficulty, but still very achievable. Directly modeling the economic impact of reducing antimicrobial resistance or reducing contribution to antimicrobial resistance, that's much more challenging. But as I say, that's something that we so far have sort of allowed the reader to infer from the outcomes that we're reporting. And then finally, a package of different technologies as well as complementary interventions is needed in order to optimize the pathway. It's not one change or one piece of technology. They all really fit together. And so it's really important for local trusts to sort of design a package of interventions that will complement each other and allow them to receive maximum benefit from the technologies they're implementing.
Hello, this presentation is about Morecambe Bay Trust's multidisciplinary approach to improving the blood culture pathway. I'm Adele, I'm one of the infection prevention nurse specialists.
I'm Peter Burkhart, Principal Healthcare Scientist for Microbiology.
So, in order to achieve our aims of optimising the blood culture pathway, we've used a mixture of education and resources, which we'll describe in the presentation. So one of our aims is to use the FAIN lab for our target as a goal to ensure blood cultures are processed in a timely way to improve rates of detection of patients with a bloodstream infection, which improves outcomes from sepsis and saves lives. Cost savings for our trust by reducing contamination and unnecessary waste and reducing antibiotic use and the associated effect of these, and we have reduced bed days.
So moving on to the third point then. So here we're actually looking at antibiotic stewardship, moving the patient's treatment from the broad spectrum antibiotic treatment to more of the appropriate targeted antibiotic, which, as we're all aware, will in turn reduce the opportunity of increasing multi-drug resistance. With the fourth point, which really follows on from the previous point, we provide a provisional basic ID with a direct antibiotic susceptibility report. With this report, there's a comment which emphasises that the result is provisional and could change, but this will provide guidance on treatment as well as alerting infection prevention staff, if applicable, with any multi-drug resistant inpatients. And again, these results will be confirmed the following day after, when we've done an actual Vitek and or mold it off identification. The next and final point we're looking at is the fill volume and ensuring the previous point is mentioned, the 4-hour vein to analyzer compliance is improved. And the next slide will provide evidence and our approach to achieving this.
But this is our pathway for obtaining a blood culture. So we involve other teams in the trust, clinical skills, and they provide the training in the correct way to take a blood culture sample to all appropriate staff. This could be support workers, registered nurses and doctors. Currently, this is only a bookable course in a designated clinical skills room.
So some of the key things is the importance of correct fill line in blood culture bottles is reiterated as part of this training. And again, it's not just adult blood cultures that we're trying to instill the importance of the correct volume, but we must remember that there's the pediatric sort of guidance as well to be followed. So as well as getting the message over that under or overfilling can have a negative effect or impact on the isolation of certain pathogens. So we need to move away from this premise, particularly for the pediatrics, that 4 ml is the maximum amount of blood that's needed. Again, 4 ml from a 15, 16-year-old child is by far an inadequate volume. So again, there's all this sort of education and training going in the hospital, along with our pediatric colleagues. So, as well as clinical skills being reviewed and training, we've also looked at the blood culture collection bag. So the current blood culture collection bag was very wordy. It wasn't particularly read by staff. Therefore, we've redesigned and increased the visual instruction with input from other teams.
So this is an image of both of the packs. The left-hand side pack is the paediatric pack. And as you can see, it's very simple and it has a paper insert. We print one off for every pack. And on the right-hand side is the adult blood culture pack. As Peter's just described, it's very wordy. And when you open the pack, it distorts the writing and staff don't read it.
So the new pack design. So we can't be there in person every time a blood culture is taken, but with the new blood culture bag design, we can perhaps be there in mind. So as you can see, there is less text. It's easier to follow with clearly stated guidance. The big change as well is the introduction of a QR code. This is linking to a dedicated blood culture / sepsis information page within the trust, which Adele will discuss further. The other interesting and important considerations as well is that this pack we've considered from an environmental and sustainability perspective. So compared to the previous blood culture pack, we've reduced the size, we've reduced the plastic content, and as you've noticed, because we'll be using this for paediatrics as well, we'll be reducing the amount of paper that's being used.
So the QR code links to a dedicated blood culture page, and currently on the page you will find information about best practices for paediatric blood cultures. We also have videos on there and other resources, but we are developing the page and we hope to include our contamination rates for the trust, the statistics for the 4-hour vein to lab compliance. We're also going to add links to the sepsis 6 pathway and also links to the microguide. So some of the challenges that we face in blood culture practice is really, the first one is training. We have a high turnover of staff in ED. This is where the majority of our blood cultures are taken. Doctors rotate after 4 to 6 months and hire trainee doctors after 1 year. And RGNs and CSWs sometimes are difficult to retain for long periods in this department. Therefore, there is a continuous need for re-education with the process of blood cultures.
Some of the additional problems for collection to load time. So here we're looking at pressures and time constraints on staff on the wards. So blood cultures aren't always being sent straight away to the laboratory. We've also discovered that in some instances, there's certain practices where staff were ordering the blood culture requests on the electronic patient requesting system several hours in advance before actually taking the sample. So almost setting us up to fail the 4-hour target before we've even started. Finally, currently the lab is open from 9 till 8. So samples after the closing will not be loaded until the following morning. So again, we've got that problem of how do we get the blood cultures all the time loaded within this 4 hours, which obviously we can't attain at the moment. However, we're hoping to get the Virtio, which once installed outside of the laboratory will allow, along with the accompanying software, to overcome one of these problems. So challenges continued. So volume of blood, we need to re-emphasize recommended the amount of blood that needs to be taken for both adults and pediatrics. So at the moment, we'll be involved in an annual audit, but again, this is manual. So again, it takes time and it takes staff to implement that. Secondly, resources. It's not just the increase in capacity to comply with the NHS England improvement recommendation guidelines. It will also impact on workload on the benches, i.e. all of a sudden we'll have doubling amount of positive blood cultures to deal with. Then we have increased pressures on support staff who will be preparing the blood culture kits, who will be loading all these additional blood cultures along with the data entry. And then obviously the increase in consumable costs and everything. So again, there's a lot to be taken into account for the additional financial and funding impacts for implementing these guidelines.
So where Morecambe Bay Trust is today, we're awaiting production of the new blood culture packs. They've actually gone to the printers now. We're waiting for funding to then be able to advise staff to obtain double sets of blood cultures. Clinical skills continue with regular training on blood cultures, and we're continuing to extract data every 2 months to monitor our contamination rates. Currently for the RLI, June last year, we had contamination rates were 6%, and for our other site, the Furness General Hospital site, it was 3%. Thank you for listening. If you'd like to ask us any questions, please feel free to drop us an email. Thank you.
Thank you very much for that, Frank. Very interesting. I'm now going to open the floor for questions. So if anybody does have any questions, please pop them in the question box. Although I do have a couple of questions to kick things off. Mark raised, Frank, that the issue of funding being a challenge for things like adding extra capacity, that often is the issue. Do you think this approach of modelling and hospitals looking to generate this real world data could be needed going forward for all aspects in healthcare and not just the blood culture pathway?
Okay, I thought you were going to ask a slightly different question there. So yeah, in relation to the blood culture pathway, yes, I think it's definitely helpful to get this kind of evidence. More broadly, yes, I think so, especially because it allows healthcare decision makers to sort of see the full picture, I guess, and see how investing in one area can save money in another area, and hopefully try to get the different stakeholders together to take a sort of system view of what the best way of managing limited healthcare resources is.
Fantastic, thank you. Another question, which this one is for you, Mark. So lots of conversations are had, and in the training sessions that I'm also involved in, whether that be on the automation or whether that be the more medical focused education for collecting blood cultures. There are always questions on paediatric blood culture collection. Is this going to be a particular focus from the UCAS point of view, or the kind of covered in general improvements?
Yeah, I think it will fit in with it all, really. I guess the any sort of filling of bottles. I mean, obviously that's one of the difficulties, of course, of the paediatrics. There's only one bottle, so an underfilled paediatric bottle may have more impact than two underfilled adult bottles, if you know what I mean. So that there is an issue with that. But I think usually where I've seen labs doing audits on things like fill volume, they have looked at the separate bottles independently. So really looking at whether the paediatric bottles are getting underfilled more than the adult bottles, and looking at it that way. So I have seen that sort of thing done, but so that would certainly be advised. But it's always worth it. There is a bit of an obscure UCAS document, TPS 63, which is about deviating samples. But the ISO 15189 also talks that any deviations from established collection procedures really should be discussed with the users. So although we talk about labs doing audits and the like to monitor things like blood culture volumes, it would really be good to consider the risks with these. And, if you do start getting lots of blood culture bottles that are being underfilled, actually perhaps even putting a comment on the reports and saying, this bottle has been underfilled. If you're sending out a negative report, it would be good to just make the user aware that that bottle was underfilled. And that can apply to pediatrics and to adults. And so that just lets the medics know they may want to collect another bottle or another set at some point.
Absolutely. And I think also, in my experience being in laboratories, using sort of middleware solutions as well, with the advance in automation to be able to track all of this data as well. Some labs do include those comments on reports, but then equally some others do not add those comments to the reports. So I think that, definitely something to improve on. A question that I actually had for you, Frank. Oh, sorry, Pete, you've got your hand up. Thank you very much for joining. I'm very sorry that you couldn't present.
Yeah, it's a shame that. No, going back to the paediatrics, we did a lot of work with some of our paediatric clinical colleagues, and again, the weight of an infant compared to the weight of a 15-year-old is quite variable. And again, if you don't know that particular weight of that child, you won't know what the correct amount of volume of blood should have been taken. So again, I think certainly from a paediatric perspective, the thrust is working with the paediatric teams to make sure that they're following particular guidance that's out there for, weight versus volume of blood to be sampled.
Would you say, at least at Morecambe Bay, that blood culture sets that blood culture bottles that are received for paediatric patients, where you say, you've got a 15-year-old potentially in front of you, the height and weight of, an adult, are you receiving sort of whole sets and not just paediatric bottles for say teenagers, for example?
So the way we've moved forward is that we've developed a specific sepsis page with that sort of guidance on for paediatric teams to follow. So again, that leads on to a lot of things that we've implemented around a QR code on collection bags and everything, so they can actually be specifically going off to a particular blood culture slash sepsis page to provide them with that guidance if they need it at that specific time.
Absolutely. Would you say as well, whilst working with the paediatric staff, how important was that collaboration between laboratory services and the wider teams?
It was absolutely excellent experience. Again, it's breaking down that accusation of working in silos. You're reaching out, working with various clinical teams, and they were very responsive and really appreciated the laboratories reaching out to them to work in tandem to hopefully provide better outcomes for the patients.
Fantastic. I guess bridging the gap as well between the laboratory and the clinicians is really important, and often miscommunication can be had, I guess. One thing just to mention as well to everybody is that Pete's presentation will be available after this webinar. We will be sharing it, so you'll all have the opportunity to watch Pete's talk, introducing the blood culture packs in the collaboration that's been had.
It's a joint piece of work with Adele from Infection Prevention as well. Yeah,
absolutely, fantastic. Another question. I'm just scrolling through the chat to find it. This was a question for you, Frank. So looking at the blood culture pathway as a whole, when the technology is kind of as innovative as it is, do you think it's more important to focus on particular aspects of, particular aspects of just the pre-analytical stage? Whether that be the actual collection or the transport and all of the considerations that need to be made when trying to make these improvements?
In terms of how labs should be how healthcare decision making should be prioritizing improvements. I guess I feel like I'm not really qualified to answer that because it's more of a sort of clinical and scientific question. But in terms of the economic evidence, I guess what I would say about the economic evidence is that it seems like the fullness of the bottles and the quantity of bottles is kind of separate from the timing. So in a sense, there should be a sort of complementary nature that if you optimize one and you optimize the other, the sort of benefits would be greater than just doing one on their own. And then I guess with the timelines, it does seem like the pre-analytical time matters, but also the time of the overall pathway matters as well. So I guess it's really about trying to optimize the whole thing rather than having just certain aspects that are functioning well and other aspects that aren't.
Sure. Brilliant. Thank you. There is another question here for you, Pete. So yourself and Adele, you've been working and collaborating with the likes of the paediatric staff. Have you been tracking the KPIs since the implementation of the improvements?
Yeah.
Or is there anything that you are planning to measure?
So there's quite a few things we're looking at. So again, as both Frank and Mark have highlighted, there's quite a few pressures, both from staffing and financial. So we've looked at various interventions that are sort of relatively cost neutral, if you like, before we can perhaps move on to the managed service contracts and get our new alerts. So the things that we've looked at is, obviously we looked at the 4-hour compliance monthly, and again, doesn't make anywhere near the 100% that we'd like. So what we've just looked at very recently is breaking it down. So we're saying, okay, at the moment, out of hours, we won't be able to reach that 4-hour goal. But what perhaps we can start to look at is what we receive during the day. So the first initial lot of stats that I've done shows that we've got an approximate 80% compliance within that 4-hour target. So the next step, again, sort of with our UCAS training in, is looking at the areas where we're not getting that compliance, look at those specific wards, or drill down further. Is it particular clinicians? And then we can start to tick that off, perhaps focus more on training or, again, communications out, and gradually building up the in-hours compliance from 80% to 90, 95 and higher still. So again, it's something that is relatively new that we're looking at, but we're hoping to further develop. And again, to support that, as you'll see on the presentation, we've looked at how we're getting that information out. So we've redesigned the blood culture collection bag. So we've taken what was traditionally a very text-heavy message that obviously people would just tend to ignore if they're very busy, and gone to more of a diagram with some just key messages that we're trying to get out there. And as I sort of discussed earlier, we've put a QR code on that then they can use and go straight to this blood culture sepsis page and get more information, from stats to where they can actually get further training on how to take blood cultures and things like that.
Fantastic. I'm just back to the chat. Thank you very much for that, Peter. Let me have a look. So Peter said that he's measuring these areas, and you mentioned earlier. Bear with me 1 second. I'm just reading through the question to make sure that I'm reading it correctly. So this one is for you, Mark. So after Pete has said he's measuring these areas, you mentioned earlier that you want to see general improvements. Is this looking at elements as and when sites can, and doing what they can, in a way of doing this rather than a scary approach to look everything all at once? So will labs be given the opportunity to look at individual stages and improve things almost one step at a time?
That's for blood cultures generally, is it, as opposed to
generally,
samples? Yeah. I mean, I think it is a case of just working on all three of them over time. I mean, you know, they're slightly different issues each. I mean, I think the fill volume one has been a difficult, but I understand from the neuroanalyzers now can monitor the fill volume by weight sort of thing, if I'm right on that. So that's going to help naturally, rather than people having to sort of manually weigh or measure bottles and things like that. So that should allow monitoring. The transport time one, you know, because continual monitoring of your audits. But I think that the difficulty is, and I was waiting for someone to ask this, is what happens when we get to a point where you just feel you can't improve it anymore. And this is where it may get a bit tricky. You know, for the two sets, for example, if you can get all your lab director involved and your clinical directors, you can take it all the way up to the chief exec. Chief exec just says no, the money just is not there. We'll keep it on file, if you like, so that when the resource comes available, if that gets to a point and the lab can evidence that they've done everything they possibly can, then I don't think Newcastle we're not going to worry too much about it at that point. We might expect it to keep pushing, but I think with some of these, there is that thing where you're going to get to a point where the lab can't really do anymore. And that's the difficulty. And so I would really expect all of these little things to be looked at, the transport, the fill volume, and even applying it to samples across the board, because if you're not getting your blood cultures in a timely manner, you're probably not getting other things in a timely manner as well. So it's the same principles for everything, really. You know, as regards to transport, if you get to a point where you've literally done everything you can and you're still averaging 6, maybe 7 hours, then you know, and you may as well think we just can't do anymore. We've done everything we possibly can, and that's where it all gets a little bit murkier then. But I'm thinking we might be a little bit further down the line before we get to that point. So yeah, so keep working on all three, because I'm sure the benefits will be seen outside of blood cultures and just with specimens generally.
Yeah, that could be a challenge for another webinar as well to discuss. If anybody else has any more questions, we still have another 10 minutes. So if there is anything, now is your opportunity. There's no more coming into the chat box. If there's no more questions, is there anything else that you feel whilst we're here, that you would like to comment on? Let me have a look. I thought there was one more coming through. I will pass over to you guys if there's anything else you would like to comment on. There doesn't look to be any more questions.
Yeah, not really. Other than, I guess, just on what Mark was saying about making the case for investment. I guess you know, there's lots of studies that were sort of referenced in the slides that I presented, and I'd really encourage everyone to kind of go away and have a look at those studies. There's some really good evidence on not only the impacts of compliance for sort of patient outcomes, but also for healthcare resource use and length of stay as well. And so hopefully that will really help people to sort of inform decision making in their areas.
Absolutely. Thank you. Oh, it looks like we have another question. Although it doesn't seem to be in, it's not in the question box. Bear with me whilst my colleague assists me with the question that I'm unable to see. Let me have a look. So, where is it? What are the manual methods? So we've got a question here. So what are the manual methods for measuring volumes? I think, yeah, I guess this is probably directed to Mark and Peter.
Manual methods. All right. I suppose Peter may know more. I think the other ones I can think of are weighing the bottles and measuring it with a ruler at the side. That's all I can really think of.
Yeah, we literally just
randomly took bottles for a whole day, weighed them, making sure our scales were sort of checked by a UCAS accredited
Nearly walked into one there.
That's it. And took into account the uncertainty of measurement for that particular way. But apart from that, no, it was literally put it on scale.
Brilliant. Thank you. Thanks for your answers. I think that is everything. Thank you very much to our guest speakers, Mark, Frank, and Peter. And thank you to all of the delegates who have joined today. And we'll wrap it up there, I think. Thank you very much.
Thank you.
Thanks, guys.
Thank you very much. Thank you.
Bye.
Bye.